I want to start by acknowledging that the land we are standing on today is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Good morning, everyone, and welcome to IPC's Privacy Day event. This year's topic, Building Trust in Digital Healthcare, affects all of us as users of Ontario's health system. For those of you here in person today, it's so lovely to see you. And for the over 1,000 people joining us online from across Ontario and Canada, thank you for tuning in. This webcast is being simultaneously translated in French. Alors, bienvenue à nos participants francophones. Ça nous fait énormément plaisir de vous accueillir ici aujourd'hui. I'd like to thank the incredible IPC staff for all their hard work that they put into this event and other related initiatives to advance our strategic priority on trust in digital health. This priority speaks to our goal of promoting confidence in the digital healthcare system by guiding health information custodians to respect the privacy and access rights of Ontarians, while also supporting the pioneering use of personal health information for research and analytics to the extent that it serves the public good. Key topics we'll be discussing today: eliminating fax machines, stopping employee snooping, and defending against cyber attacks, while also building a transparent and privacy-respectful culture, are some of the fundamental conditions for earning public trust in digital healthcare. As we speak, First Ministers are preparing to negotiate a funding transfer agreement with conditions that will drive fundamental changes to healthcare delivery in this country, including data sharing. Transformation is in the air. Ontarians and Canadians have spoken their minds and want to see much-needed improvements in the healthcare system. Nearly 3 years of pandemic conditions overburden emergency departments, sparse access to primary care, and an exhausted healthcare workforce have worn this country thin. Sustaining our publicly funded healthcare system will require innovative approaches and new digital solutions. The changes we see coming out of the new funding agreement will add to the many changes already afoot here in Ontario, including the creation of Ontario Health Teams. OHTs, as they're called, have sparked community-based alliances between different health and social interveners to provide better integrated continuity of care, and it looks like this bold experiment is here to stay in one form or another. To be successful, change upon change requires a strong foundation, and that foundation is public trust. In healthcare, that includes trust that health providers will respect patient confidentiality and keep secure the personal health information imparted to them. Without trust, patients will not be forthcoming about the symptoms they're feeling or tell the truth about their adherence to treatment plans. Worse, they may avoid seeking help altogether. They'll be hesitant to adopt new digital solutions. They won't agree to participate in research or allow their personal health information to be shared for broader public health purposes, particularly if they fear that information about them may be used to further stigmatize or marginalize the community or groups they're a part of. As the old adage goes, trust takes years to build, only seconds to break, and forever to repair. Today, we'll be hearing from a panel of privacy and healthcare experts on potential trust breakers, such as misdirected faxes, employee snooping, and cyber attacks. but we'll also be discussing how to build trust by creating a transparent and privacy-respectful culture. So let me introduce these themes to you. According to privacy breach statistics that all health institutions must send to my office on an annual basis, misdirected faxes continue to be the leading cause of unauthorized disclosure of personal health information in Ontario. In 2021, 51%, almost 5,000, the unauthorized disclosures reported to the IPC were due to misdirected faxes, mercifully down from 58.5% the year before, but still far too high. Last week, my office released a report about the high number of privacy breaches at a regional hospital due to misdirected faxes. This report not only provides important insights for healthcare providers about the risks of using fax machines, it also shows significant efforts that can be made to reduce misdirected faxes and the use of fax altogether. It's a good news story about how stakeholders can work together to replace faxes with more secure digital forms of communication. And we're going to hear more about that story firsthand by one of its central protagonists. This theme aligns with the joint resolution that my office, along with Canada's federal, provincial, and territorial privacy commissioners, issued last September on securing public trust in digital healthcare. The resolution outlines measures for adoption by governments, health institutions, and providers, including a coordinated plan to phase out fax machines and unencrypted email and promote the adoption of more secure digital technologies and responsible data governance frameworks. I want to reiterate here today our office's standing offer to work with governments, regulatory colleges, health institutions and providers, and others to put an end to fax machines in healthcare. Fax machines that unnecessarily expose individuals to potentially harmful privacy risks and undermine trust in the system as a whole. Now, that being said, we recognize that axing the fax is not so easy. We're going to hear why that is and what concrete steps have been taken so far and can and must continue to be taken to move health providers towards more secure and interoperable forms of digital communication, incrementally and over time. Another persistent trust-breaking issue is employee snooping into health records. Whether out of malice, personal gain, mere curiosity, or well-meaning concern about the health of friends and family, snooping through medical records can have devastating consequences for patients, health professionals, and the healthcare system as a whole. While the reasons for snooping may vary, the end result is the same. It undermines patient trust. Reports to our office for 2022 reveal that snooping by healthcare workers accounted for 29% of self-reported health privacy breaches. That's an increase from 21% the year before, reflecting a disturbing and persistent trend we've been seeing over the past few years. We need to work together to stamp out snooping once and for all from our healthcare system through appropriate sensitization and awareness training to prevent unauthorized and inappropriate access, however well-meaning, and through effective disciplinary measures when not so well-meaning. To help deter snooping, Ontario's Health Privacy Law, or PHIPA, was amended in 2020 to give my office power to impose administrative penalties on those who seriously breach the Act. While we are still awaiting regulations, before administrative penalties can take effect, our panelists will explore how this new enforcement tool can be used most effectively to curb bad behavior, like snooping, while still encouraging good behavior. Now, the healthcare system has become familiar with a concept of just culture that takes a calibrated approach to addressing medical errors. from time to time, health professionals make mistakes on the job. They're only human. A just culture to medical errors uses a spectrum of responses ranging from consoling, coaching, and systemic course correction, with disciplinary action and sanctions reserved for only the most egregious cases that justify them. Just like medical errors, privacy breaches too range in severity. People make unintentional mistakes, and as a modern and effective regulator, our role is not just to administer orders and penalties, but our much preferred approach is to help organizations learn from their mistakes, correct them, and prevent them from happening again. Our third theme today is cyber attacks that have unfortunately become an increasingly dangerous and pervasive threat to the security of personal information in all sectors, including the health sector. In fact, this is part of a rising global trend in cybercrime and ransomware attacks worldwide, particularly since the onset of COVID-19, with increasing frequency, especially against public sector institutions, critical infrastructure providers, and essential services. In 2021, the number of health privacy breaches reported to our office due to cyber attacks was double the number reported to us in the previous year. And in 2022, from what I understand, those numbers continued to rise. Cyber attacks threaten not only our economy, but the very infrastructure of our society that can bring critical services like healthcare to a grinding halt. They're particularly daunting for smaller healthcare organizations that process large volumes of sensitive personal data, but don't necessarily have the financial resources to mount a foolproof cyber defense or pay hefty ransoms when they do get hacked by malicious actors. That's why smaller organizations need to be strategic about their cybersecurity measures, build up their resiliency, and band together to share resources and know-how to the extent possible. This means taking a risk-based approach to investments in technological resources, but also investing in people by ensuring staff are aware of the threats, how to avoid them, and what to do if a breach occurs. With that in mind, my office recently updated a fact sheet that provides technical tips on protecting against ransomware attacks. As Benjamin Franklin once said, an ounce of prevention is worth a pound of cure. Ensuring employees understand the threat landscape through ongoing cybersecurity training is essential to shielding any organization from potential threats, especially when it comes to phishing. Just as important as strengthening defenses against cyber attacks is giving the employees the proper tools they need to respond to attacks when they unfortunately do happen. This includes having a well-coordinated and well-rehearsed cybersecurity incident response plan with clear roles and responsibilities, communication protocols, and escalation procedures. So stay tuned for more on these and other practical tips by our panelists who will share their experiences and perspectives on how to manage this very challenging issue. And finally, the panel will conclude with a discussion on how a transparent and privacy-respectful culture throughout an organization can help build and sustain public trust. On a previous episode of our Info Matters podcast, I had the opportunity to speak with one of the panelists about their approach to building an organizational culture of privacy at their hospital. And she's here to share that story with a broader audience today. A story about how data privacy and security must stay top of mind and be addressed throughout an organization, starting with its board of directors and C-suite executives. How staff at all levels of an organization can come to see their role of protecting patient privacy not only as an obligation, but as a mark of pride. how privacy and IT security need to be better integrated cross-functionally and as part of a broader enterprise risk management framework to ensure that risks are mitigated accordingly. We're also going to hear from other panelists about the key role that education plays in raising awareness about privacy and security issues and inculcating an innate sense of respect for patient privacy as part of an organizational culture. And finally, we'll discuss how transparency and a privacy-respectful culture are part of the necessary trust-building conditions, the sine qua non, for implementing Ontario's ambitious plans to future-proof its healthcare delivery model in a more financially sustainable way. Modernizing our healthcare system, particularly through transformative digital tools and enhanced data sharing, will have to have appropriate governance structures and processes in place to sustain that foundation of public trust on which the entire enterprise critically rests. Just as trust is the glue of life, according to author Stephen Covey, trust is the epoxy that will hold our healthcare system together in whatever future shape it takes, so that it's there, standing solid and ready to help our loved ones when they need it the most. So, as you can see, we have planned a fascinating discussion for you this morning, and with our lineup of accomplished guests, it promises to be an interesting and engaging conversation with many key takeaways. I know I will be listening keenly and intently for ideas and insights. So all of you here and online, please don't forget that you can submit questions to the panel at privacyday@ipc.on.ca. And with that, I'll hand things over to Eric Ward, our Assistant Commissioner, to introduce our panelists. Thank you.
Please come and take a seat. It's great to see you in person. It's great to see you online. And it's a huge pleasure to have more than 1,000 people joining us online today on a Friday morning. Thank you so much for joining us. And also to all of you who've made the trek, put on your snowshoes, and come into downtown Toronto on this Friday morning for this great panel. Now I'd like to introduce our panelists today. And it's really important to always start at the beginning of your cue cards. We have with us first online Sylvie Gaskin. Sylvie is the Chief Privacy Officer for Ontario Health, where she leads a large team of privacy professionals. Sylvie is responsible for overseeing the day-to-day operations, including strategy and planning the privacy program. She's a certified information privacy professional for Canada with the International Association of Privacy Professionals, and she's performed a big service for the community by being an advisory member on its Certified Information Privacy Professionals Exam Development Board. Some of you may have taken that. And so welcome, Sylvie, glad to have you here with us virtually. Now I'd like to introduce Michael Hillmer. Michael is an Assistant Deputy Minister of the Ontario Planning and, at the Ontario's Capacity and Planning and Analytics Division of the Ministry of Health. And Michael is also an assistant professor at the University of Toronto's Institute for Health Policy, Management and Evaluation. Welcome. Next to Michael is Wendy Lawrence. Wendy is the Chief Risk, Legal and Privacy Officer at St. Joseph's Healthcare Hamilton. Wendy was previously in-house counsel and academic health sciences centers. Prior to that, Wendy was counsel at the Ministry of the Attorney General. And next to Wendy, we have Nyranne Martin. Welcome, Nyranne. She's General Counsel and Chief Privacy Officer at the Ottawa Hospital, which is one of Canada's largest academic health sciences centers. Nyranne is a trusted advisor on legal risk, on privacy, governance, and policy. She has worked as in-house counsel also for the Canadian Association, at the Canadian Addiction and Mental Health, CAMH, and in private practice. Nyranne is currently an adjunct professor at the University of Ottawa, Faculty of Common Law. Welcome, Nyranne. And then next to me is Ariane Siegel. Ariane is General Counsel and Chief Privacy Officer at OntarioMD. That's an organization that helps physicians, specialists, nurse practitioners, and their staff adopt and efficiently use digital health technology to care for their patients. Previously, Ariane worked in private practice advising on technology law to major global corporations. She's worked as a senior investigator for the Federal Privacy Commissioner, also as law clerk to the Chief Justice of the Ontario Court of Justice, and as constitutional counsel to the Attorney General of Ontario. So thank you very much, online and in person, for joining us. It's a distinguished panel, and we're really looking forward to hearing your answers to the questions that we've organized for you today, and that will be put on to us in person and online. So as you're listening, please do think about the questions that you'd like to ask this panel. Okay, I've recovered from not having my cue cards in order, and we're ready to start. Let's begin by exploring our first theme, which is faxes in healthcare. I want to start with Ariane Siegel from OntarioMD. Ariane, what are some of the on-the-ground challenges for practitioners, the real practical challenges as they make the switch towards more secure forms of communications technology? And I'm thinking particularly of sole practitioners who aren't part of larger institutional or regional electronic health record systems. What are they facing?
Absolutely. And so, as Eric indicated, my background is that of physician stakeholders and other healthcare providers. But like each of you, I also bring the perspective of a patient or a caregiver to the patient. So we all have a vested interest in solving these issues. To really understand the use of fax machines across the province and really across the country, one has to understand the landscape for the exchange of patient health information. So there is no universal health record yet in this province or in the country. The reality is fax machines are cheap, they're easy, and they're reliable. They're really a product of the time at which they were invented and implemented, which is the 1980s and 1990s, a long time ago. And so they were implemented before we had fancy systems to exchange and collect and use patient health information. Patient health records are not stored in a standardized way in all healthcare settings. So for example, in the hospital setting, we have health information systems that Nyranne and Wendy will be very familiar with. These are huge infrastructures that support the use and collection of information. It's not that easy to get data out of those systems. With respect to the community, meaning your family doctor, specialist, they have smaller systems. These are called electronic medical record systems, and they operate in the province in order to connect to provincial digital assets. OntarioMD certifies them. But all the systems don't speak to one another yet. And Ontario Health, together with the Ministry of Health, are working on a gold standard of data exchange, and that will solve many of the problems, but we're not there yet. Right now, we need interim solutions to get data out, to exchange information, to promote patient care. My organization offers Health Report Manager. It's a secure and reliable way of getting information from hospitals to your family doctor. With small investments, that technology can continue to provide a very reliable interim solution. Long term, we need perfect data exchange, we need universal health records, but that's still a bit of a time off, so we have to make do and improve those secure methods of communication and exchange.
Great. Thank you very much, Ariane. And maybe I'll turn to Michael. Now, you have a position of leadership in the Ministry of Health that's specifically related to this question. And what can you tell us about the status of the Axe the Fax initiative in Ontario? And I know you've been consulting recently on that. What did you learn in those consultations?
Yeah, great. Thank you for the question. And Commissioner, great opening remarks. Thank you for having me. many years ago, I was in a role where I had oversight of the provincial health information privacy legislation, and recent change in the ministry brought me back, and I see some familiar faces here, so it's really great to be back. And I took part in the work that made the changes that allowed information custodians to send you those statistics so that you're able to cite those and actually understand some of the magnitude of the issue. So it's great to see them now being used to highlight ongoing policy issues that need to be rectified, like faxes. So your remarks, really framed the fax use kind of as potential privacy breaches, which they are. But I think as we build up the digital infrastructure of the health information in this province, they're going to become, getting rid of faxes, moving to digital communication will become the bedrock of how care is provided. And I think that part that's the true benefit. I mean, you'll get rid of these inadvertent breaches, but you're going to increase efficiency and increase satisfaction and increase, I think, the provider experience. And I had a great experience recently. I'm on the board of Canada Health Infoway, and the Ottawa Hospital's chief medical information officer came, and because you're right on the verge of integrating Prescribe It, which is the federal initiative that allows e-prescribing. It's one of the major tools that will allow us to get rid of fax machines. And you're right on the verge of integrating it with Epic, which is fantastic. And he characterized it by saying, I can prescribe something, and then I can have a digital exchange with the pharmacist. First of all, I know that it got there, which you don't know with faxes. And second, the pharmacist can ask questions and clarify and challenge, and this can all happen digitally, quickly, instead of trying to phone the person, find them, they're not there, and then opportunity is lost, and you lose the moment. And so the modernizing provider communication initiative for us at the ministry is clear. We want to absolutely phase out fax use. And we know that there's about 80% of fax use is related to 4 use cases: prescribing, referrals between physicians, lab ordering, and diagnostic image ordering. So if you can have easy to use digital alternatives on top of each of those use cases, you're going to phase out faxes over time. And so the initiative for us is providing change management supports for practices and integration points for HISs, so that you can help people move along, because faxes become so normalized as part of workflow, because for all the reasons that were mentioned, and you have to move people, and I think there's a couple different movement points. There's practices that have only faxes, and then you need to migrate them to digital alternatives. There are practices that have e-faxes, which are, I think, one step up. But e-fax is only so good as what's on the other end, and you might have an actual old school fax machine, and then you end up back where you started. So you really do need to phase people to these digital alternatives. And our goal is, over the next 5 years, is to like I say, eliminate 80% of the fax use. And I'll share one sort of personal anecdote. My wife is an internist, and she was trying to prescribe Paxlovid to somebody, and the person was from Hamilton. She's an internist here in Toronto, and she just could not get a hold of anybody at the assessment center, and so she had to fax it, and it was intensely frustrating, because she just had no idea if it got there. And Paxlovid is one of those drugs that time matters. You get it into the person, and they have much fewer complications of COVID. And the person got the prescription, but it's those moments like that real clinical benefit is at risk. And then who knows, maybe there was the privacy breach on top of it. So I think these are all the reasons we're very motivated to move on this initiative and make some progress. Thank you.
Great, thank you, Michael. And thanks for bringing together the healthcare quality and the privacy and information aspects of this. They really do dovetail. Wendy, let me ask you, St. Joe's did experience at one point a very high level of misdirected faxes, and that was the subject of a recent report by the IPC. but you've turned that around. So how did your institution manage to reduce not only the number of misdirected faxes, but also your reliance on faxes altogether?
Yeah, Eric, that's correct. We did have an opportunity to, through the IPC's review of our 2020 incidents, to really take stock of our faxes and really do a root cause analysis. And our learnings and our improvements were twofold. One was using the incident review process itself to drive improvement, but the other was really about being deliberate and seeking out alternatives in small, deliberate steps to faxes. So maybe I'll first touch base on those alternatives. We identified and encouraged a few initiatives in a couple of areas to secure alternatives and find secure electronic solutions. One of those initiatives is called e-referrals first, and we piloted that in 2 key areas of the hospitals where referrals are used to drive up quite a few records. And you can just imagine how many transactions occur with a referral. You book the referral, you confirm the referral, you consult on the referral, and the records are flowing as a result of that. So we use an e-referral system for that, and we were very deliberate. So we communicated internally that for these 2 high volume areas of the hospital, we have an e-referral first policy. And that means that we use our system unless there is a technology constraint on the recipient side that does not enable them to integrate into our e-referral system. And secondly, we were deliberately and communicated that with our partners on the recipient end, that is our expectation that the e-referral system will be used in these 2 areas. And we did have a lot of buy-in in this, and it was great, and we are expanding it. And we are hoping now in our region, partnering with 2 other hospitals in the region, that for all diagnostic imaging orders, that we will be using this e-referral system. And another initiative we applied occurred in the long-term sector, and you can just imagine that hospital to long-term care transfer is a high volume transfer, and one where the transfer of information is vital and important for patient safety. But there needs to be a mechanism for that information to be flowing, and we found that in addition to fax, telephone had to be used a lot to transfer information between providers. So our hospital, which is part of the St. Joe's Health System, used a pilot with our long-term care partner, and our 2 organizations launched a data integration project for information to flow with transfers and continuity of care, and we're now expanding that to other long-term care centers outside of our system. I think the final initiative we took was simply really having a campaign for using secure portals. So what we realized is over the years, providers adopted portals, but we at the hospital end may not have been aware of that and may have continued to use the fax. So we had an active reach out campaign to those local providers. And back in 2020, when we had this large fax incident, we were only using secure portals to transmit documents to 300 community providers. And today, as a result of that campaign, almost 7,000 are using secure portal to secure portal transmission. So those are just examples with identifying solutions, but then also being deliberate and communicating the importance of it. The other side of our review really was using that incident review process. So of course, through mandatory reporting, we all have an obligation to annually take stock of incidents, to analyze them, and to report them. But I think we really realized the value in a more frequent cadence and really, picking a cadence that works for us with faxes because it was such an imminent and important issue. We actually review that particular category on a bi-monthly basis, learning from our experience. And that really gets engagement at your staff to address the issue point in time, to be vested in it. And the other part I will say about incidents is that we took a lot of lessons from our clinical colleagues and applied those principles used for patient safety incidents and applied that to our review of privacy incidents. So we now review privacy breaches in the same way we would review a patient safety incident. So that means that we take an approach with the view to system improvement and learning. So we're not there to blame individuals for making errors. We're there to learn, and we're there to identify system solutions. Secondly, we take a broad approach. So we don't just review privacy breaches, we review near misses. So those incidents that could have been a privacy breach, it was a close call, but it wasn't. We also look at policy breaches, and I think all of those examples have really important learning value. So taking a broad approach is helpful. And then finally, we share those learnings. So it's not just an exercise for your local privacy office or department, it's an organizational exercise. So in our reviews, we bring in organizational and clinical leadership. Our managers are really engaged in that, and that really allows for buy-in to your remediation steps. And it also provides for a culture of privacy.
Great, thank you, Wendy. And it's such an inspiring story. And for a regulator, that really wants to be, the IPC is a modern and effective regulator. What a great experience for something that starts out with a reported breach, and it was, thank you for reporting that correctly, and then that turns into this learning experience, reforms, and here you are today on the stage providing a real value for the whole community. This is exactly the kind of regulatory interaction that makes it great to be at the IPC. And let me turn now to Sylvie online. To what extent can technical specifications for digital assets help address the interoperability issues? We're looking here for some of your expertise on this more technical question.
Hi, and good morning, everybody. I really believe that standards play a critical role by providing consistency.
Hi, Sylvie. I'm not sure if you...
I really believe that standards play a critical role by providing consistency and... Sorry, there's a bit of a delay, I see. You're all good. Okay. So building that consistency to the collection and exchange of health information across the health sector in a manner that's secure and considers privacy protective measures. I can talk a little bit about the work that Ontario Health is leading currently, which is geared to establishing and updating interoperability standards for the digital assets that it makes available provincially to healthcare providers through our provincial electronic health record. Standards for the digital assets that it makes available provincially to healthcare providers through our provincial electronic health record. So the goal here is to have more and more healthcare providers contribute to a central and provincially available electronic health record. So whether they're using, no matter what health information system or electronic medical record that they may be using. This allows for a more comprehensive provincial electronic health record and allows providers to have a more fulsome view of the context for patient medical records. So they have all of the information that they need to provide care centrally available to them. If the healthcare community and the vendor community all follow the same interoperability standards, then it's a lot easier for contributions to be made to a central and provincially available electronic health record, and also for that electronic health record to be accessed by healthcare providers across the province. This gives providers more choices in terms of vendor selection and sets up providers who may be less digitally mature, sets them up for success by streamlining the exchange of health information through more secure and privacy protective digital workflows and provincially available digital assets. May not completely eliminate the use of fax or email, but certainly reduces the dependency on them and reduces some of the other pain points that have been raised earlier by my fellow panelists.
Great, thank you very much, Sylvie. And we can think about this in across the span of time. The heyday of the faxes was in the early 80s. Some of you may remember that. It was also the launch of MTV. I think Video Killed the Radio Star was the first song ever played there. We will see at some future IPC event whether this community ends up axing the fax. And that'll be a great day to report back on. I wonder if our panelists have any more comments. We have just a couple of minutes if you want to follow up on anything that you've heard your colleagues here say. Yes?
If I can just add, I think when we talk about the issues of where are the areas where fax drives privacy challenges, we talk about prescriptions. We also talk about referrals. So if we think also of what are the challenges that the health system is facing currently, access for primary care and for patients and communities to specialist services is a real challenge. So I know out of my institution, primary care has gotten together and with support from the ministry to do e-services. So my colleagues have talked about this already, but e-referrals, e-consults, that's how you get patients quickly and effectively into, I guess, either through their primary care provider to some kind of discussion with a specialist or facilitating that referral. So at the same time that you're solving a healthcare challenge, you're addressing the privacy challenge because it's safe, secure, privacy protective, and those kinds of things. What you're always looking to do is address both issues at once.
Ariane?
And I'm so glad Nyranne raised this. It's an issue that goes beyond privacy into workflow, because not only are we balancing the range of interests, patient care, number one, privacy, but also physician workflow and burnout. And so how do we bring these together? So there are incredible applications and technologies out there. The reality is many healthcare providers, not just physicians, like all of us, are faced with increasing amounts of information coming in. And I don't know about you, but I think about how do I keep up with everything? And I know that my physician colleagues feel very much the same way. So I think the answer partially lies in making sure data is coming into the healthcare provider's workflow, physicians, nurse practitioners, allied healthcare providers, so that they can manage all the points of information that they need to act.
And Michael?
Yeah, thank you. I mean, I think the panelists' comments have been, they really exemplify the opportunity and the challenge. And OntarioMD is such an important organization about workflow and making it simple, standardized, integrating into the EMRs. The ministry has a big role, funding change management support and the tools themselves, and then, OntarioMD working with the vendor community in doing the integration, and then, organizations like St. Joe's and Ottawa Hospital and primary care clinics then have the really hard work of building up the coalitions and doing the change management and working through the issues on the ground. And you see, really takes that whole continuum of policy funding, to like on the ground working through the frustrating aspects that sometimes grind digital initiatives to a halt. And without all those things working together, you don't make the progress that you hope to see.
Great. Thank you, Michael. And really wonderful to hear how axing the facts is not just about a separate compliance activity, that you're really building it in as part of improvements and in fact helpful improvements for people working in the healthcare system. So thank you for that. Now, so thanks for those insights. Let's move now to our second theme, and the Commissioner mentioned this in her opening remarks about employee snooping. We're talking here about intentional, unauthorized access to personal health information. Now, employee snooping into patient records, we know it undermines everyone's trust in the healthcare sector. We're hoping to see the introduction of regulations to implement monetary penalties under Ontario Health privacy law that might deal with exactly this kind of behavior in some cases. But how do we ensure that introducing penalties into this complex system, that they have their intended effect of encouraging good behavior while deterring really bad actions? What potential unintended consequences of a penalty scheme should we look out for, and how can we mitigate them? I'd like to start off with a question for Michael. Can you tell us a bit about the work that we're anticipating on administrative monetary penalties? What would be the intended purpose of that? And how can they really help us support trust in the healthcare sector, given that the intention is not just to increase punishment out there, it's really to make this system work and increase trust?
Yeah, thank you for the question. I think this idea of the administrative monetary penalty, or the AMP, has been used it is used in other sectors in Ontario right now, and it essentially allows an independent arbiter like the Information Privacy Commissioner to adjudicate against a set of criteria and levy a fine. And those things are set out in regulation, the amount, the criteria, and that's the work that we're doing right now. So in 2000, several years ago, the ministry introduced a digital first for health strategy, and it was really, one key component was modernizing how we share information in the province simultaneously while strengthening privacy protections, because they have to go hand in hand. Because I think you mentioned it in your remarks. We're only as good as the trust we build in the people who are sharing their information with clinicians. And if you increase the amount of information sharing, which we're doing with digital initiatives, and I'll talk about Ontario Health Teams a little bit later. We want information to be shared, to be used, improve health, population health. But if you can't show the twinning of that with what will happen if people are maliciously, snooping or hacking or any other kind of bad activity, you decrease trust. So in 2020, we introduced into the PHIPAA the ability to create AMPs with a regulatory framework, and that's what we're doing now. And we see it happening. GDPR has an AMP framework, and some other Canadian jurisdictions are looking to build it into the health information privacy framework. We believe that Ontario was the first to put it into the health information privacy legislation. Now we have to enact it. And I think what we want to see is that with these criteria, working closely with the commissioner and her staff, a framework that allows a more nimble and proportional response to bad activity. Because we know that right now, criminal prosecution, it is an incredibly high bar. Crown attorney time is a scarce resource, and it doesn't always hit their radar. I mean, they have a lot of, really odious activity that they're looking to try and prosecute. And I think this will provide an addendum to that, leave the criminal prosecution for the absolutely outrageous, huge economic benefit, huge harm, and then allow the AMP framework to go after the issues that fit the criteria. And I think the unintended consequences are, it creates a chill. And I think that's what we heard in our consultations. Provider groups, don't want to feel that, through inadvertent, non-malicious activity, leaving a chart in a stairwell or the kinds of, activities that humans do because we're humans. That would be the travesty, is that, people start to just retrench and not share information. So I think the proportional, transparent response is really important, and lots of education. When the criteria get set, I think the first few are going to be really important, Commissioner. I think they have to be really, really important. I think they're going to have to be a huge public education campaign to say, this is about the kind of activity that if you read about it, you go like, oh, that's not right. Somebody should do something about that. And like that's kind of the gut check that I think people would feel really happy about. And how you manage that in a kind of a formal regulatory set of criteria with on-the-ground practice. Well, that's where I think working really closely with your office and the provider groups and the public, and making sure that we constantly tailor and reevaluate. So it's a piece of work I'm really excited about working on with your office, and hopefully we'll be able to get it into action soon.
Great. Thanks, Michael. And that's good to hear that distinction between things that people do in good faith by accident, because humans are humans, and those that are really egregious, that give us that feeling like it's not right for that to stand. That AMPs are, that administered monetary penalties are aimed at. Now, from humans doing what humans do to artificial intelligence, Nyranne, you put in place an AI-enabled tool at the Ottawa Hospital that detects and diagnoses potential employee snooping cases early on and helps nip them in the bud. This is really interesting. Can you tell us how this technology works, and what have you learned from the cases it detected? Has it been effective in reducing snooping there?
Yes, so thanks very much for the question. I think in the context of today's discussion, it's really important to remember that the overwhelming majority of healthcare providers earn and keep the public's trust on a day-to-day basis. And it's rare situations where there's either an error, a mistake, we're human, we all make mistakes, or where there's really sort of rare, inappropriate activity going on. So in that context, what you want to have is a bit of a trust but verify structure. So most of the time, we know that people are doing what they ought to do. They're using information to provide care and to do their jobs. But occasionally, you need to be able to both detect and deter those breaches. So a number of years ago, with these things are always a team sport. So with colleagues from the technology team, working with the IPC, we developed a bit of a pilot where we learned a tremendous amount about the technology and the behavior so that we could go from a place of auditing randomly, which those of you who have to do that will have the experience perhaps of it being a ton of work with very little payoff, to really getting to a point where you can focus and target the kind of activity that you're worried about. And that's what things like artificial intelligence permit you to do. So you're going from a scenario of looking for a needle in a haystack, which is an endless activity, to having the needle jump out of the haystack for you. So in getting feedback and collaboration with the IPC about what kind of data we could put in, we started to be able to detect, okay, people with the same last name, that would jump out. Well, if you have a name like mine, my last name, Martin, there might be a lot of Martins out there. There is only one Nyranne in Canada that I'm aware of. So those might jump out. So how do you make sure that you adjust for those kinds of things? Very important. Looking at postal code data. So if it could be that I'm looking at a number of different Martins, but wait a minute, if it looks like a neighbor, now that's concerning. And what do you do with all that information? We talked earlier about information overload. You can't always act on all the information that's coming across your screen. We're in a sector of an incredible volume of data. So how do you filter and act on it? So this was where, in collaboration with communications, we were able to develop targeted messaging that would go automated to areas where the use cases began to look concerning. So if you're sitting there and out of concern, you see your neighbor walk into the emergency department and you look them up, but you're not in their circle of care, you might get a friendly email from the privacy office saying, "Good morning from the privacy office. We've noticed the following." And that, if you were doing something out of concern, which is inappropriate, versus I'm looking up another Martin that's in my circle of care, you would be able to explain your activity. You'd be able to have a conversation. There could be coaching and communication. And it can have the right sort of impact if all of a sudden there's a number of people getting a hello from the privacy office. So it's that sort of targeted response that we're looking for. And I think an important piece here was how much we learned through that process, because our technology has since evolved since we developed this tool. But what we learned about the frequency of behavior, the range of behavior, how to engage people from a communications, education perspective, how to automate our efforts so that we could be as efficient and effective as possible. And then finally, how to evolve the technology that we use now over time with what we learned there. So that was a great, learning journey for us so that we could get back to the point of, okay, how do we trust but verify in a way that's really going to make a difference for behavior and improve a culture of privacy protection?
Thank you for that. It's a fascinating example. I'm sure we'll be seeing more of this kind of work of coding the regulatory checks in the area. Now, Nyranne, that was so good. I'll go back to you for the next question. You've also had experience applying a just culture approach, and the commissioner mentioned this in her opening remarks, a just culture approach to medical errors at your hospital. So that's also interesting when we think about how administrative monetary penalties might play a role in the larger mix of our regulatory responses. So can you tell us what just culture means to you and what you've learned implementing that approach?
So Just Culture was implemented in my organization a number of years ago. And again, this is a team sport. Full credit to many of my colleagues on the people side of the house, on the quality side of the house that championed this. And what you're trying to do is evaluate the quality of people's choices. And this happens in the medical error scenarios. It happens in the privacy scenarios. And what you're trying to avoid there is targeting individuals when actually perhaps there's a system problem. Or they had a really bad outcome, but somebody else made the same quality of choice and just happened to get lucky. It was a near miss. So what you want to do in a just environment where you have a proportionate response, as was alluded to earlier, is to really have a whole system view on how people's choices operate in an imperfect system. So if I think of an example of people speeding on the highway, okay? So does the police car need to chase every person that's speeding? Do they only chase the one and go to the one that ends up in the accident, although other people were perhaps driving faster? You can look at these kinds of things, and if what you're worried about is the quality of those choices, what if everyone on that highway starts speeding? At a certain point, has it just become acceptable? So if I take that back to the healthcare example, you might have an individual who's doing something that we all know is wrong, right? You look up the health record of your ex-boyfriend because you're curious about what they're up to, okay? Those are rare scenarios. It might be out of concern. You see your family member walk in, or you want to access your own record, which is not a privacy concern, but it's a policy one. So at the end of the day, what we try to do, as imperfectly as no doubt it is to look at the quality of individual choices within a system environment, and then be honest with ourselves. Where do we need to improve our education? Have we done the right training? Have we followed up on our attestations on an annual basis to make sure that people are reminded of their obligations? Because we can only hold people to a certain standard if institutions and as a system, we hold ourselves to a high standard as well. So I think that allows us then, in many cases, to coach and console those who make a mistake, and in rare situations, to bring more severe corrective action to bear. And that builds, again, credibility and trust with the health professions and with healthcare workers, as well as the patients who entrust us with their sensitive information.
Thanks, Nyranne. And that really brings us, we start with AMPS and how it applies to an individual, and this really brings us back to a kind of system, a system and behavior approach. So really appreciate that. And Wendy, now whereas we've been speaking about penalties being imposed or trying to catch clues of a breach after it's taken place, what interventions could help curb snooping behavior, irrespective of the motive, before it happens?
Yeah, it's a really great question, and I think taking a step back, that curbing of snooping and unauthorized access is a really important responsibility that we all have as healthcare organizations. And I think that duty and that responsibility is even heightened once you have an electronic system, because you have vast volumes of patient information that you are providing your users with. And I think back to earlier comments by others in the panel and the commissioner, it's that expectation and that trust relationship you have with your patients that you will be safeguarding your information. And I think when you have an electronic system, in developing a compliance program, you really need to think about that foreseeable risk. And unfortunately, that foreseeable risk is unauthorized access. So a couple of things I would say with approaching this from a compliance perspective. One is the rules need to be very clear, and I think, as Nyranne alluded to, I think people know and are very understanding that a malicious access where someone clearly does not want you to be looking at their patient information. You are clearly not having any medical or professional relationship that needs you to do that. I think everyone's very clear in that rule. But I think there are a lot of gray areas. You may have a colleague whose relative is in the hospital, and your colleague's not feeling really well, and you're probably curious, what's going on with this colleague's family. And that is still inappropriate, but I think that motive may come from a good place, and it's not so clear to the user that still is an unauthorized access. So I think in your education and in your rules, being really clear about what is unauthorized, what are the very limited reasons you should be accessing a health record. The second part, I think, of our education and training is focused on the consequences. So what happens once you are involved with a privacy breach? So we are very clear that there are consequences, and similar to what other hospitals have in place, our consequences are framed in just culture. So certainly if it's an error or due to lack of understanding, that is addressed through education. But if it's in disregard to rules that are very clearly provided, there would be more serious sanctions. So we're very clear that there could be discipline. We're very clear that consequences could include interactions with a professional body if you're professionally regulated. We also talk about what's done after, that there's a report to a regulator and that patients have to be notified. And we found in our most recent training that it wasn't very obvious to our organization and staff that we would actually have to notify a patient and tell them and inform them of the circumstances of how and why their information was breached. And this really stood out to people, and I think explaining that is part of the privacy breach response really was a strong deterrent for individuals in thinking twice before going into the record, even if that access is not for a malicious purpose, but for a purpose that is still not a work purpose. And then I think finally, we used auditing as an education opportunity. So we are very clear that our electronic systems are audited and monitored, but when we do actually have our actual audits and an individual is selected through an audit to explain their access, we use that as a second education opportunity and explain that you were selected because we have a privacy compliance program, and that really requires us to verify access, and that's why you were selected. And that really resonates with that person. They know to expect that. They tell their peers and their colleagues that these systems are audited, and you can be caught if you are accessing it for a reason that is improper.
Thanks so much, Wendy. And now let me turn it back to the panelists if you'd like to respond to something that you've heard or amplify.
Maybe I'll jump in because I am so amazed by the discussion by my co-panelists and really interested in the developments, how we're using technologies to take us in a better direction. We also have to always ensure that we're introducing a human dimension to the conversation, because technologies can sometimes also make errors. And I'll give you one example. I remember dealing with, at the height of the pandemic, we had there were concerns expressed that snooping was going on and looking at a particular file because, and this is in the electronic context, because it looked like a file was opening, a patient record was opening. What was actually happening is that the technology detected a file to be opening when someone's hand was hovering over a mouse pad. Mm-hmm. And so in fact, it was only after replaying the situation and testing it that we could determine that in fact there was no snooping. This is just part of the pattern that was occurring, and it was resolved that way. But these are important lessons learned, and the lessons that Wendy has expressed will continue to take us in the right direction.
Great. Thank you very much. And it's wonderful to see the kind of maturation of the thinking in this area about how we regulate, how we prevent, how we educate, how we identify, how we respond. I think maybe if we had the same conversation 10, 15 years ago, there wouldn't have been this level of really sophisticated response, and happy to see that happening in the organizations. Thank you all. Now we're going to take a 15-minute break, and we'll see you back very shortly. Encourage people who are here in person to go and visit our excellent pastries and coffee. And if you're home, well, I hope you have access to the same. Thank you. Thank you for coming back, those of you in person. And the more than 1,000, we're so pleased about that, more than 1,000 of you online who are joining us. I hope you are are back. I don't know if you're like me, if you are working at home, you have that feeling like so far from my colleagues, so close to the half-opened bag of chips in the kitchen. So I hope that you've had a healthy snack, that you're back with us. Thanks for joining us. I'd now like to turn our attention to a really crucial question of protecting personal health information against the risk of cyber attacks. Now, there's so many examples of institutions dealing with this challenge. It continues to evolve and change. It's not getting any easier. The threats are becoming more complex, and the attack surfaces, especially in a very distributed IT situation with people at home, are very difficult to manage. The threat landscape changes so quickly it can be hard to keep up. The IPC recently published some important guidance, and I hope you'll all have a look at it on our website, on guarding against ransomware in particular and mitigating its effects. But we realize that there are limits to the resources that all of your institutions can pour into cyber defenses, no matter how important that is. So this is it's a difficult area of decision making. And Nyranne, let's start with you, and then we'll move to Wendy for this question. How do institutions make real-world risk-based calculations about cybersecurity and how to mount a reasonable defense against this evolving ecosystem of cyber attacks and ransomware?
Thank you very much for the question. So responsible institutions in this day and age have to take steps to protect themselves against cyber threats, which continue to increase. Now, we also are responsible stewards of scarce public resources, and we're all watching with interest how funding will be allocated, what kind of transformation is going to be needed to do things differently and continuously more efficiently. So these kinds of topics could be the source of endless investment. And so all institutions have to do an exercise of balancing. And that's where, in my institution, we've tried to focus a lot on how to integrate risk analysis with strategy, so that you're getting both your achieving the goals that you're trying to strive towards in terms of improving access to care for patients, improving the experience, the patient experience of their care, as well as addressing risks along the way. So a good example is our EMR. So we have a health information system that brings with it tremendous cyber improvements, right? You have a much more secure system than various small pieces of unconnected technology, more stable systems. At the same time, what you're focused on is improving that patient experience. So how do you get patients logged onto, in what our case is called MyChart, so that they can access their records in a timely fashion, so that they can have secure chats. So I think what's important is making sure that you're doing risk-based decisions, but connecting it also to your strategy. We spoke a little bit earlier about consultation services. So our health system is under real strain to get folks access to specialty care. If you are waiting, knowing that you have met with your family doctor, you've got a concerning test result, and you're waiting months to get access to specialty services. Well, we have to do what we can in our sector to facilitate timely access. So a consult where a family doctor can log on and have a quick chat with a neurologist to get a sense of whether you really need to go on to that list or whether there's something else that can be done in the meantime, that's huge. There's a huge impact on the patient experience and improving their outcomes. At the same time, that's a secure method of transmission, which reduces your cyber threats. So that's where aligning your risk analysis with your strategy and ensuring that your investments achieve your overall objectives for service to a community, as well as reducing your cyber threats. So I think in an environment of scarce and limited resources, that's how a risk lens can be brought to bear.
Great, thank you very much. And Wendy, maybe to you on the same question.
Well, first of all, I think it's important that we frame this really as a risk issue. I think cyber resilience is no longer an IT issue, but really it's a key enterprise risk issue. And it's an issue that most, if not all, boards and leadership teams identify as a top risk. So I think an enterprise risk approach is really important with that. And when you're faced with limited resources and an evolving and continuously growing threat, I think what you do is you prioritize your risk mitigation strategy and you prioritize compliance, and you use that to apply an enterprise risk approach. So what that means is that you identify the risk, and then you consider what are those mitigations that you're going to apply and other actions to bring that risk level down to an acceptable level of risk. And really with cybersecurity, you're not going to be able to eliminate that risk. It really is about targeting an acceptable level and putting efforts into bringing that risk level down. So in terms of how you determine what that acceptable level of risk is for your organization, I think an important starting point is that legal framework. So what are the legal obligations you have? For those of us under health privacy legislation, of course, that standard is to take reasonable steps to protect information. And we know that's been further interpreted for those reasonable steps to evolve as the environment and technology evolves. And we also know that courts and the IPC have interpreted reasonable as comparable to what others do and the best practices in the industry that you operate. The other piece in prioritizing and balancing is balancing those technological defenses with those human-based ones, such as training and cyber awareness, and also balancing your defenses with your readiness plan. Because we know with attacks, it's not a matter of if you will be attacked, it's a matter of when and the severity when that attack does occur. Now, certain jurisdictions and industries, critical infrastructure being an example, may be subject to more prescriptive standards that go beyond data protection. Some examples include having security programs, disclosure and record-keeping obligations. And you may want to consider as a risk strategy whether you adopt those and kind of consider whether others in your industry or maybe a similar industry are doing so. Another strategy you may want to take is consider the benefits of mapping to one of those accepted industry cybersecurity standards. So examples of those include the NIST framework, the CSC controls, and the ISO framework. And mapping to that is considered a best business practice, and it just demonstrates you really are adopting a strong security posture and standard of care. And then I think finally, with any risk exercise, it needs to be continuous. You need to continuously monitor your internal and external environment and continue to really confirm that you are meeting the regulatory standards and that you can demonstrate, should an event occur, that you have taken reasonable steps and steps that are in line with best practices of peers in your industry.
Thanks you so much. And so we've heard sort of two perspectives on fairly large institutions, sophisticated institutions. And, but Ariane, can you follow up by telling us about the practical tips that you offer to health practitioners in the community, many of whom are joining us today, on how to protect themselves in terms of cybersecurity and what you advise them also on this question of insurance?
Sure. So we can hear from the discussion, Nyranne and Wendy have framed the maturity that exists at the hospital level. I try my best to be the voice of the 25,000 community physicians who are out there, your family doctors. And what our chief medical officer likes to remind me is it's important to let doctors be doctors. As patients, we know and we want that to be true as well. Most community physicians, family doctors, have very small practices. They wear the hat of the physician. They wear the hat of the administrator, of the IT professional, of the chief privacy officer. So that necessarily means a very, very busy, highly accountable day. And so how do we make cybersecurity and privacy practices and accountability most meaningful? I have been trying to advocate for a bundle of products and services that can support these practices at a meaningful level. What does that mean? It means not perfection, but a combination of tools, education and training, prevention tools, and response and administrative support. So from an education perspective, in 2017, in partnership with Ontario Health, my organization, OntarioMD, rolled out provincial privacy and security training. one-stop shopping for community physicians to take privacy and security training. Free, online, available 24/7, and it's designed by doctors, for doctors, and their support staff. So it encompasses the circle of care, and it's not just meant for physicians, it's meant for all support staff and allied health professionals. It's case-based scenarios, learning from mistakes, learning from real-world problems that physicians and other community health support staff face. So we've been able to take that module and further refine it together with Canada Health InfoWay and the Medical Association. In 2021, we rolled out virtual care training. Now, luckily in partnership with a program that Ontario Health pioneered, the Regional Security Operating Centres, and with UHN and HSN, we've taken that to the next level. Privacy and security training for staff who are not just in the community, but also in the hospital setting. And so by rolling out provincial tools at that level, we can take the conversation to the next level. In terms of practical tools and resources, again, it's basic things: DNS firewall, multi-factor authentication, updating devices, and of course software. Password, having a password policy in place and changing those passwords frequently. I hear one day technology innovators are going to get rid of passwords altogether, and I can't wait for that to happen. We're not there yet. So we still have to be updating our passwords and having complicated passwords. On the response side, governance agreements, they're critical. Having an incident response plan and learning from the mistakes or near mistakes that your organization experiences. But again, for community physicians, it's a hard conversation because they're spending their days treating patients. And so how do we make time in the day for absolutely everything? From an insurance perspective, again, and there are lots of different cyber insurance offerings out there. The Medical Association, our parent company, offers one. There are many others out there. These are important conversations for clinics to have, and really it'll depend on the risks that are experienced and what's really necessary in that context. These are bigger provincial issues that have to be tackled. I don't think the conversation is at its end yet. There are different policy implications, and I think they have to be well thought out.
Thank you, Ariane. Sylvie, I'm going to turn to you now. We just heard from Ariane that what we know, which is not all health practitioners, particularly smaller clinics or community centers, can mount the same level or exactly the same type of cyber defense. But we've been hearing that Ontario Health has recently partnered up with the Ministry of Health to develop operational centers that can assist the smaller players to build their cyber resiliency. Can you tell us a bit more about that, Sylvie?
Absolutely, and I'm really excited to share and talk about this particular initiative. So our cybersecurity business partners here at Ontario Health, through a partnership, very strong partnership with the Ministry of Health and the Cybersecurity Division of the Ministry of Public Business Service Delivery, have established a provincial cybersecurity model that enables the healthcare sector to better prepare and defend itself against cybersecurity risks at a regional and at a local level. So the model really supports a collective, centralized, and strength in numbers approach to securing healthcare providers, large and small, against the ever-evolving threat landscape. It equalizes the resources that we heard the panelists talk about. So it equalizes capabilities, people, processes, technologies that are required and that the healthcare sector needs to have access to. It removes silos so that no organization is left behind in terms of cyber defense and cyber response. So over the last couple of years, Ontario Health, again, through these provincial partnerships, has tested and evaluated the model through the execution of 6 regional security operating center pilots called RSOCs, as Ariane alluded to earlier. Participation in the pilots included more than 40% of provincial acute care sector organizations, so large hospitals, medium-sized hospitals, in addition to other health service providers within their respective regions. The model is really positioned, as we heard before, as cybersecurity as a team sport. It really is no longer reasonable or practical for healthcare organizations anywhere in the province to go it alone with respect to cybersecurity attacks, responses, or resiliency. And so through this particular model, through transparent and coordinated efforts to identify, protect, respond, and recover from cyber attacks, it really has given the opportunity for those healthcare organizations to uplift their maturity with respect to cybersecurity resiliency. The model is continuously evaluated and changed depending on lessons learned and any gaps that are identified. It has been found to have found some financial and operational efficiencies, and also enabled some of the healthcare organizations that are participating to better meet their insurance requirements. The model, for me, having had the privilege of watching it evolve over the last couple of years, has really showcased the importance of what we've talked about earlier today in terms of leveraging and building those strong partnerships across the healthcare sector, but also within our organization. So building strong partnerships with privacy or cybersecurity teams, communications, our business partners, to really make sure that we all understand each other's vital role in building our provincial capabilities when it comes to cybersecurity defense and response. The plan for these regional, these RSOC pilots, is to leverage lessons learned and to accelerate the expansion of these across the province and beyond acute care sector organizations, and to start including more and more of those smaller providers that may not necessarily have those resources or maturity levels that the other partners may have across the province.
Now I'll turn it back to our panel if you'd like to amplify anything that you've heard, or pick fault and start an argument at your option.
I certainly won't do the latter, but perhaps just to amplify on my co-panelists' comments around the RSOCs. So my institution has the privilege of leading one of those. And to Ariane's earlier point, each one of us plays an important role in the system. So my colleagues in the IT space have tremendous expertise when it comes to cybersecurity. Ariane's world is going to know what's happening on the ground in the real life experience for physicians and more community practitioners. Everyone has to find a way to work together and bring their perspective to bear to make sure that we can address these significant risks, because cyber issues are only continuing and they are certainly here to stay. So it is it truly is a team sport and one of mutual aid within the sector.
Michael.
Thanks. This is a great example of capabilities that manifest themselves that you want to have at a system level and a provider level. And I really commend Sylvie and Ontario Health for leading the work on the regional centers of excellence, because the small clinic will never have the resources to mount a strong defense, but we can't, as a system, let them not have that. So, but also at the same time, you want to have organizations, manifest their full accountability as well. So I just think it's a really interesting policy debate that, how do you set that level correctly? And I think this is a nice posture where we have good central support led by technical experts like Sylvie and her colleagues at Ontario Health and at OntarioMD, but then ensuring that individual providers are taking their obligations seriously, buying the right insurance, updating their practices, but then having that backstop of provincial resource and best practice to look to as well. So, we have it's so important that we can't let individual providers not be amazing at this because it's so risky. I mean, examples of sick kids recently, and and now when the systems go down, it is catastrophic. I mean, care is jeopardized. Like, there's no doubt about that. It's not just an inconvenience. Like you hear the doctors talk, and they're like, I don't think I can do my job effectively, and that puts me in huge moral distress and puts patients at risk. So you just have to keep investing in this. It's so important.
Thanks, Michael. And as we move into this sort of deeper and deeper digitization, that question of class break is really important. That before things were networked, if you wanted to break one car, you had to take a hammer to one car. Once everything is networked, there's a potential for breaking a whole class of vehicles all at once. And so it's just crucial, this kind of work. And I'd like to shamelessly plug our new ransomware guidance on the IPC website. Do have a look at it. It gives a good sense of the general principles and sort of where the requirements come from in the law, but it also gets into the weeds and should help people in a practical way to think through some of these issues. And as the Commissioner said, an ounce of prevention here is really worth a pound of cure if you think about it from the day that, as our panelists said, that there is an attack where you are facing that. That's a good day to think about in terms of how you prepare. Well, I'd like to go from there to this question of fostering a privacy and a transparent privacy, respectful culture in organizations. As an efficient and modern regulator, we know that culture is just crucial for how compliance happens out there in the real world, and for the real world outcomes for patients and for Ontarians. So real trust in digital health, we know it starts with building a transparent, privacy, respectful culture from the top and across the whole organization that recognizes the confidence that we as individuals place in our health providers. And we know that's critical also for good health outcomes. We don't want people to hold back information from their healthcare providers, to know that they can engage in full confidence with them. So I'll pose this question to Nyranne and Wendy and Ariane. How can organizations successfully build and sustain that sort of transparent, privacy, respectful culture that people can trust? So let's maybe start with Nyranne.
So thanks very much. I think what we end up talking about is how do you get from the board all the way to the bedside? And when you're talking about culture, it's the thing that happens when you're not watching, right? It's what you do every day, day in, day out, in terms of your interactions, your communications, how you handle issues. That's what comes out in terms of your culture, your organizational culture. So how do you foster a privacy protective culture? I can speak to the experience of an ongoing journey in my institution, and it really has evolved over time. So at earlier days, it was about understanding what are some of the foundational components of a privacy program that you have in place, and kicking the tires. How strong are they? So what's your policy, your procedure, that kind of core component suite? How is it implemented? How do you know how it's implemented? How do you audit? How do you test? How do you communicate in a layered approach? Because we know, if you're a custodian in a hospital or a frontline nurse, you are not sitting at your computer reading your email. So how do you communicate the importance of privacy protection in a way that meets people where they are in their workday, in a way that speaks to them and motivates them in terms of their core function, which is provision of care or supporting care, which is really what health workers do. So it's finding a way to come at people and communicate with them in a variety of ways. It's having the commissioner come and have a conversation. It's posters. It's how you handle your corrective action when you have a significant privacy breach. So all of that comes together and then has to change over time. How do you take oversight and governance to evolve with where the organization's at? Because I can tell you, in healthcare, like in most places, nobody needs to be at meetings any longer than we have to be. You want to have the right people at the table to have a good conversation to move something forward. And at the end of the day, that gets people motivated and interested in things like privacy. And perhaps there's just a final remark on this question. We have found, privacy is fundamentally a compliance function in a lot of ways. So how do you switch that to becoming a bit inspirational or aspirational? Because you want people motivated and engaged and not just being told what not to do, being talked down to. Frankly, that doesn't go anywhere in the long run. What you want to have, and what we learned in our institution, again with support from our communications folks, was we pivoted to a communication around being proud to protect privacy. That speaks to healthcare professionals at a different kind of level. So I think each institution knows where they're at, what will speak to their environment, from a board level right to the front line. And making sure that over time you adjust is really critical. We certainly have done a lot of adjusting in the last few years.
Thanks, Nyranne. Wendy, over to you. How do organizations successfully build and sustain this transparent, privacy-respectful culture?
Well, for the past year at our hospital, we've really been on a journey to rebuild our privacy program, to refresh it, and really, restart that journey of a privacy culture. And we have done a few things. The one I alluded to earlier is our incident process. So really treating privacy incidents with that same rigor and importance that we do and give to patient safety incidents. So we really have transparency over incidents. We have many people involved in the review of them, and it's a learning opportunity, but it also really fosters awareness and compliance by taking that system approach similar to patient safety. The other thing we do is we share those reports with all levels of the organization. So now on an annual basis, our board receives a report on privacy, and that really has elevated the importance of privacy in our organization. We also regularly report on that to a hospital committee. And when we have significant breaches over the past year, what we did is we actually were transparent, and we discussed it with our patient and family advisors, who are important members of our community. So I think that transparency really can do a lot for building a culture of privacy. Privacy is also part of our enterprise risk report that really ensures that our trustees and our leadership have a top-down understanding of this risk, and it's seen as an enterprise risk, not really a risk that just lives with the privacy department. I think education and training is obviously really important, but keeping that training relevant is more so important. So when we refreshed and created an annual training program this past year, we had input from our physicians, from other clinicians on what are the key issues we need to address. And we also used our incident data to highlight the key risk areas. So our training program addresses very topical issues such as social media, such as remote work, such as using regional shared EMRs, for example. And I think it's important to not just educate, but make sure that education is relevant and current. And I think the final thing and approach that I have is that everyone's a privacy officer. So again, it's not just knowledge that lives within the privacy team. It's knowledge that you want to share and make accessible to everyone in your organization so that everyone is doing the right thing to protect privacy. And when they don't know what the right thing is, they are really encouraged to seek that guidance and information so that they do the right thing to protect privacy.
Thank you, Wendy, and congratulations on that work. Ariane, on this question of a privacy-respectful and transparent culture.
So I like to remind colleagues and audiences I engage with that physicians had built-in obligations around privacy and confidentiality long before privacy legislation ever existed. And evidence shows, and I know Canada Health InfoWay did a study on this even recently, that patients trust their physicians, number one. And so an important part of the conversation is making sure that when we're talking about healthcare, physicians and the relationship with patients is maintained at the core of the governance conversation. From a practical perspective, my co-panelists, Wendy and Nyranne, have done an incredible job of framing how we build trust through the board, through our executive teams, through the CEO, And as partners with everyone in an organization, our technology teams are critical to that dialogue and the evolution to make sure technology and trust are integrated together. In a physician practice, our number one focus has been on education and training. But through that education and training, there are practical tools and resources. So in our online training, we attach templates and we attach additional resources to make that conversation a practical one. Consent forms, template service provider agreements with accountability requirements built in. These are all a critical part of the trust conversation. It's amazing to hear between the commissioner's work, the ministry's work, the conversation is shifting away from penalties and really towards practical compliance and what does meaningful privacy entail. And so these are positive messages. How do we make privacy and trust an enthusiastic and positive conversation to lead us in new ways? Canada is a great strength in privacy and innovation, and together this conversation merges, and it's a true privilege to be part of that discussion. Thank you.
Thank you, Ariane. And now, Michael, I'd like to get your take on this and maybe your views on how this fits, how this question of culture fits into some of the work that's happening at the ministry. So can you tell us about some of the transformation taking place in the province's public health care system and the role of the Ontario health teams? What are the potential benefits for patients and privacy? And how should we think about public trust and privacy and transparency in enabling these major initiatives?
Yeah. Excuse me, thanks for the question. The Ontario health teams, many of you are maybe involved in an Ontario health team in some capacity. And they hold a lot of promise, and jurisdictions like the UK and US with their accountable care organizations show that when you bring providers together and really integrate care pathways around the patient, you can achieve that quadruple, quintuple aim and seek out value. And to realize that, it's both shared organizational goals and collaboration, which takes negotiation, governance, and clinical harmonization, which is really hard, important work. But it has to rest on this idea of shared information. And I think PHIP is really clear in that the health information custodian has really broad ability to use information. And you see that with leading hospitals and large primary care practices. They use that information to look at the whole group of patients and try to characterize their health status and look for opportunities. That's what we want, in opportunities to improve health. I think where some of the challenge lies is when you start to bring multiple organizations together and they're just flummoxed by how they can share information. There is no standardized digital tool that they can do that with, and because I think for me, the most important part about an Ontario health team that distinguishes it from what we would expect primary care or other organizations to do is this whole population health mandate. You look at your entire group of individuals, characterize their health, their risk, and then reach out to them and invite them into care opportunities. But right now, we hear from on the ground that when OHT partners come together, they're unsure what to do. Do we need a data sharing agreement? Does PHIPAA allow us to do this? And maybe it does, but maybe each organization has a different interpretation of what PHIPAA allows them to do. And I think that becomes incumbent on us, ministry, commissioner, to lay out some parameters by which OHTs can come together in a standardized way and share information really clearly. And the ministry released the Path Forward document recently, and it does talk about this idea of incorporation, which I think is important because I think it sort of gives you an organizational construct by which you can then start to think about sharing information. there are always options for groups to merge together as health information custodians. That's a big step, though. I think, I don't think a lot of organizations are necessarily willing to do that because it entails a whole raft of procedural work that I think is maybe not the best use of time. So my goal is to, I think, set up clear pathways by which OHTs can both share information digitally, and that comes through continued investment in the electronic health record and all the tools we've been talking about, but then also how do you let them do population health management so that they see everybody in their attributable population, whether they use healthcare services or not, and then have the ability to reach out to them, and it's very clear how they do that and the means by which they do it, that is following PHIPAA. And I think it's a real conversation about whether we need to continue to modify PHIPAA to do that, or whether we just say this is how we collectively think is the acceptable way that PHIPAA can do it now, and we don't need to change it. I think we need to go through that exercise, and I think and again, trust comes from transparency. You just tell people how that you are bringing their information together, how you're using it, and convince them that it's to their benefit, and give them the opportunity to opt out. That's how we've built our system, and that's how we'll continue to do it. So I think those. But I think it's really important that we give standardized pathways, just like the cybersecurity. Like you need standardized pathways, because otherwise there's going to be too much inefficiency, duplication, churn that we don't want these organizations to do. Like their mandate is to care for people, and we know information sharing is central to that, so we have to make it easy. So that's my accountability as a policymaker. Make it as easy as possible, and let them get on with their mandate of helping people get healthy.
Great. Thank you, Michael. And are there any other comments from the panel on approaches that institutions and organizations can take to foster a transparent, privacy, respectful culture? And Sylvie, there's a bit of a delay, so if you'd like to speak, just give me a wave and I'll know to call on you.
Maybe I'll jump in.
Okay, over to you.
Okay, awesome. So one of the ways that we can do that as well is by embedding privacy and security into the tools that we make available provincially. And when the pandemic hit, we saw a real adoption in the use of virtual care solutions, so virtual visit solutions, as a way to bring providers and patients together where they couldn't necessarily get together during the pandemic. And so one of the ways in partnership with OntarioMD that Ontario Health has been able to make available those solutions in a way that will reassure and build trust is to establish a standard with respect to virtual visits, vendors and solutions. And so we built a standard that vendors who make available virtual visit solutions must attest to having in place. So privacy, security, technology requirements and standards that they have to make available, and also test against to be verified and published on the Ontario Health website as having met that standard. And so providers and the healthcare community that are using those tools can rest assured that those solutions that they're using to deliver care to patients across the province have considered those privacy and security measures that are really important in building trust. And to date, there are I think 39 vendors that have been verified as meeting that standard and have been published, and that information is made available to the healthcare community, but also to the public.
Sylvie? Others? Okay, thank you. I would also like to take a moment to share that the IPC has a really talented and creative communications group. They work with everybody across the rest of the organization. They produce some excellent materials that relate exactly to this question of trust and culture. In particular, I draw your attention to 2 episodes of our Info Matters podcast, in which the Commissioner expands in conversation with experts about building a culture of privacy and security in health institutions, and also putting patient trust at the center of virtual health. They're excellent resources, and I think you'll once you see those, you'll want to listen to the others. These episodes and more are available on our website at ipc.on.ca or wherever you get your podcasts. So now, before we wrap up and take your questions in the room and online, I'd like to invite all of our panelists to share any final thoughts or provocations or take-home messages that you think might stimulate some questions or that you'd like to speak to. Michael.
Thanks. I would encourage people to look at the recently released Ontario Health Data Council report. And this is a group that the minister appointed, chaired by Dr. Jane Philpott. And it's got system leaders, thought leaders, bioethicists, clinicians, CEOs. And I think they lay out a nice pathway around the power of data at every level, clinically all the way up to system planning. And we'll be relying on them to help chart the path forward around, how do we do this twin objective of using information for good and continuing to strengthen trust and transparency and strengthen privacy. And the commissioner sits on that council as an ex officio member, so we get the benefit of her counsel as well. But it's a good report, and I think it's a nice, cogent, thoughtful articulation of the power of data in a modern healthcare system.
Nyranne.
I think it's an important opportunity now, as we're sort of shifting focus from day in, day out in the pandemic to what the future holds now in the healthcare system. And we had tremendous leaps forward in terms of, for example, ambulatory care being done entirely virtually. Many institutions were able to increase their efficiency by doing certain things digitally and having their interaction in the health system be more focused. So I think there is a real opportunity now as we move forward to look ahead at what are the innovations that we're going to support, what's the research that's going to help us do better, and privacy protection is just going to be embedded and walk along that path as we go, but I think it's an exciting time in the health sector.
Thanks, Nyranne. Now, we are heading into the question round. So first, maybe I'll open it up to anyone who might like to ask a question in person. You get first shot for having come down to be with us this morning. Is there anybody, if there is, just raise your hand and signal. There are folks with, we have one over here. We've got folks with microphones who will come and bring them to you.
Hello. Thank you, everybody. I think part of building trust in digital healthcare requires that we use data to provide value back to the public. But often that is difficult because you have to grapple the privacy risk involved in using patient data for insight, for research. I was wondering if any of the panel participants could maybe share an example where they had to grapple with that question of, I want to do something that I think is valuable right now, but, I'm unsure because of the privacy risk and where you landed with that. Because I think that's something that a lot of people might struggle with in this space.
Great practical question. Thank you. Let's turn to our panel.
Sure, I could start. So I think different kinds of organizations will handle this differently. But it does go back to balancing risks, and in an institution like mine, articulating a tolerance or an appetite for what kind of risk you're willing to accept. Because at the end of the day, there's no perfect solution. Status quo is rarely acceptable at this point. You do have to move forward to do things differently, to do them better. And there can always be privacy risks that you have to manage. And you try to mitigate them as far as you possibly can, be as creative as you possibly can. And then there does come a point where institutions, individuals need to say, have we done enough? Can we live with some level of comfort that we could look our patients in the eye and say we did what we thought was best? And so that to me comes down to what can you tolerate and what are you willing to accept?
Thanks, Nyranne. Michael.
Thanks. As the other part of my role is data analytics lead for the ministry, and there are probably 4 or 5 really amazing pathways to getting quite a lot of data. We maintain a system tool called IntelliHealth that has information on all Ontarians. If you're associated with kind of an institutional address, you can sign up for access. There's a data sharing agreement that you sign on to when you log on. So that's one pathway. We take in requests all the time for data sets. We've got the Ontario Health Data Platform. ICES, 30 years of doing just that. But I think what I'm excited about is moving forward, just because insights don't often require the actual PHI. I think, and this is again, I'm good colleagues with Dr. Alan Forrester, and he's doing some really interesting work with synthetic data sets. And so I think we've got to use technology to help us address these issues. So researchers typically don't need like Michael Hillmer, my age. They need some representation of me, and I think we can, as a system, continue to experiment with things like that, and synthetic data sets radically reduce the risk of re-identification and some of the things that get us really antsy about using data for that reason. And I would say I'm excited about exploring that at a system level, and would encourage organizations that have the wherewithal to do the same, because I think it's a promising way forward.
Thanks, Michael. Now I have a question that's coming to us online, and it's directed to Sylvie. So Sylvie, from your perspective at Ontario Health, how will organizations that transition to digital health applications also ensure that they continue to provide access to those who manage their health in traditional, in-person means?
Can you repeat that question again?
Yes, there is. And I'm sorry, we've got a bit of a delay here. This is actually a real good meta example of working virtually. So the question is, how can organizations that are transitioning to digital health applications still make sure that they continue to provide good access to those who are managing their health in traditional means, either using paper-based approaches or in-person visits?
Right, so that's a really interesting question. So I guess at a provincial level, we continue to expand our ability to make health records available to a large volume of providers across the province. And as organizations are transitioning, I think it's really important to keep in mind, again, those access rights of individuals to access their information. Ontario Health is also working in partnership with the ministry to make the health information available through our electronic health record available digitally to individuals across the province. But it's also, I think, important to continuously improve the means of giving access to individuals. So as you're transitioning, making sure that you don't lose sight of those privacy protective and security protective measures, but also always looking forward to those improvements in technologies and looking forward to accessing more provincially available resources that reduce the volume of flows of information, I guess, and put privacy and security at risk. So really, I think it's keeping all of those, keeping that balanced approach, moving towards more technology-enabled solutions, but not losing track of the ability to be able to meet the rights and needs of individuals across the province. Hopefully I answered that question.
Thank you very much, Sylvie. And do we have any more questions in the room? Just raise your hand. You can identify yourself or not, as this is a privacy respectful organization. Nothing yet from the room, but I know something is brewing there. So why don't I go again to a question from online. And this one is directed to Wendy or Ariane. And our online viewer asks, how can organizations communicate to their patients that they are cybersecurity prepared and that they're able to both protect information as well as to provide care in the event of a cyber attack? So I guess this is a question not about internal processes, but what would you be willing or able to say externally to give comfort?
Yeah, it's a great question. I think we are all required to have a statement of information practices, and it has that very narrow prescriptive things to put in there. But I think when you look at most healthcare organizations, what they do put about their practices has really evolved and expanded over the years to really meaningfully tell patients what is done with their information, why we are using information in that way, and when those approaches are new, what we are doing to protect them. So I think it is incumbent on us to do that. Of course, with cybersecurity, I think we would never be going into the details of any vulnerabilities or risks, because that could put our organizations and our data at risk. But I do think it is important for us to be communicating to patients and the public that we are being responsible with carriage of their data and outlining the steps we take.
Thank you. Yeah, Nyranne, do you want to add to that, or Ariane?
Ariane?
Sure. So I think part of the conversation goes back to topics that Sylvie and Michael touched on, which is how do we make some of the standards meaningful? In the situation of 25,000 community physicians, it's supporting them with template privacy policies, the sort of reflections that they need to make, the conversations they have with patients. It's also about the apps that are out there and the secure messaging platforms, which allow for the meaningful conversations to continue online. I know my physicians communicate with me electronically, and some of these apps make it very easy to do that. They're integrated into the EMR, and they allow for that exchange of information. Your in-person encounters with physicians, where they have these conversations with you directly and can share with you information about their practices and what your expectations are and how they can continue to meet them in a meaningful way.
Thanks, Ariane. Now we'll look again for questions from the audience. Don't be shy. Oh, good. Over here. You did come all this way. It didn't used to be all this way, but now it's all this way when you go in.
How fancy. I was just wondering, you've mentioned some really, interesting new innovations in the industry, and this transition for example, from older technologies such as fax machines to secure portals in digital communication means, as well as the use of AI in detecting unauthorized accesses. I think that's super interesting, as well as the use of synthetic data for research purposes. So I was just wondering if there were any other possibly additional emerging technologies or even threats that are sort of on the horizon in the industry that haven't yet been mentioned here today.
Okay, so a question about the future, the emerging future. Over to our panel.
Yeah, I could offer one thought. I think it's on the AI thread, and we see some of the major HISs are starting to build in machine learning, automatic tasks, and this will just happen more and more. And so I believe there's policy work we need to do to get ready for this, from a clinical regulatory perspective to a technology perspective, and then to a conversation with patients' perspective, and because I think the ability for really sophisticated medical chat agents will just get better and better, and I think I've started to talk with my colleagues about how we get ready for that, and if you could, I imagine a hypothetical future where AI agents are operating within HISs and EHRs and there's a range of tasks they could probably do. They could do administrative tasks that are frustrating and time-consuming that we would happily give to them, where the potential consequence of their decision-making is low, and then all the way to the kind of work that Dr. Mohammed Mamdani is doing, where he's building in medical distress alerts into actual medical systems, and then working through how that clinical workflow works. And so I think this is happening at the pinnacle of innovative and forward-looking organizations, which is amazing. And I think it's we just need to look to see that our regulatory framework is ready for it, and that we've thought through the pros and cons, and are just ready for what this is going to look like in much faster than I think maybe we are expecting right now.
Great. Thank you. And for any AI or large language models who are watching today and part of our 1,000 applicants, welcome. My, how you've grown. It's a big month for AI, and that's a great reminder that there's a lot new happening in terms of what AI can do, and what people are using in and outside the healthcare and public health system. I'd like to follow up that question with a kind of practical and interesting question here for anybody any of you who've worked with a just culture approach. Did you encounter any resistance to a just culture approach, to this way of thinking? What kind of challenges did it pose, or what did you have to overcome when you were implementing a just culture approach?
So yeah, maybe I'll take a first cut at that. I think sometimes the person who's been impacted by a privacy incident may feel concerned that the person was not disciplined and they were just educated and retrained. So I think within the healthcare system, we're really familiar with just culture. It makes sense to apply a just culture to privacy the same way we do to clinical and patient safety incidents. But I think someone aggrieved by a privacy breach may not understand that. And I think you need to unpack that a bit with them and explain to them, well, yes, a privacy breach is a privacy breach, but there are different dimensions of that. There's that root cause analysis we do, and certainly if someone is being human and it's resulting from human error, and they have a great record of completing their privacy training and being astute with the rules, but this is a one-off, we're certainly not going to terminate their employment. So I think having that dialogue and explaining that, but there can be pushback when someone is affected by a privacy breach and is looking for some action. Mm-hmm.
Yeah, great intervention, and speaks to what do people expect from, what do they think justice is in this area, and what counts as being serious about it. Thank you. Anyone else from the room? Yes, in front here. Hi. Oh, we'll wait for a microphone to get to you.
It's absolutely wonderful to hear all that the panelists have had to say with regards to privacy and security innovation all across healthcare space, from ChatGPT to Stable Diffusion coming into our lives, very recent innovation. I worry about some of the legacy systems that are out there. I worry that as modern healthcare is picking up pace at a rapid rate, what are we at large as a medical community doing about those who are falling behind? You've got your smaller clinicians who can't afford it. Like you had said, you've got the one guy, gal, who's doing everything under the sun. Where will they get the resources to stay up to standards, to keep pace?
This is a great question and a good challenge in a system that, things don't all change in lockstep, do they? You've got brand new sort of generative AI at the same time as I'm sure there's folks looking around for trying to bring COBOL programmers out of retirement to help fix their legacy systems. So let's go to our panel. How do we deal with this?
Excuse me, I could offer one thought, but I'd love to hear others. I think it's much like the cybersecurity discussion, where innovation and equity are simultaneous goals, and how do you optimize on both of those? It's challenging, but I think Atul Gawande, he wrote a great piece, The Century of the System. Medicine is going to be more and more about systems. And if you build these tools into systems, it's not going to be any different than bringing up a little viewer to see what drug somebody are on. If it's built into their EMR, EHR, I think if we do our jobs correctly and we integrate, and great partners at Ontario Health and OntarioMD are thinking about these things, they just become another tool. I mean, we've had drug safety alerts in systems for decades, and so I think if you what's the next manifestation of that, and that we're always mindful that we're being transparent about how this is happening. And that we work closely with clinicians who have to use these systems, and that they're offering value to the clinicians and the patients, and you build them into the system. I think we can move that along, and then we have to work with regulatory colleges and medical schools to make sure that these new core competencies start to get built up. So that's why I said we have to get ready as a system. It can't just be Ottawa Hospital or St. Joe's as peer leader and that just happens. Everybody needs to be risen up, because I think the opportunity is enormous. But if you don't do it right, you end up with inequity, and then that's inequity of both, I think, the clinic and the patients, who then are maybe missing out on the benefit that could come from it.
Thanks, Michael. Ariane.
Sure. And Michael's absolutely right. The conversation about technology and systems is a critical one in our evolution on the path towards adoption of technology. It's people that are at the heart of the system. And so how do we build systems which satisfy what you and I need from those systems? And how do they support us? And that's why it's important we revisit our policies and our laws and our technologies on a regular basis and learn from what's happened before. Canada has always been a world leader in innovation and communications. From the days of Marconi to the mainframe, to the old switchboards and the rotary dial, and to the heavy wireless devices that we carried, to the little computer systems we now carry in our pockets and purses. Like mobile technology, like other systems, the health information systems that support our healthcare system will also evolve. And but at the end of the day, it's critical that we remember people are at the center. We need to work with our regulators, with our policymakers in health. That means the CPSO, it means the IPC, it means the courts, it's doctors, it's patients, advocates. It's about sustainable funding. And it's not just about Ontario. These are Canadian and global conversations which have to occur at the same time.
Great, thank you. And I would love to keep this conversation going, but I see that we are now at 11:56, and it's been a great discussion. I want to thank everyone in the audience and online who submitted a question. And we've kept track of some of those, and they will continue to help us in our work and as we think about future events. So thank you for that, and thanks for the engagement. We have way more here than we could ask. Now I'd like to turn things over to my great colleague, Assistant Commissioner Warren Marr, who's got the Herculean task of synthesizing, bringing this all together for us, and sort of knitting it together for us across the whole morning. Warren, over to you.
Thanks very much, Eric, and I want to thank our panel guests as well for a really dynamic and inspiring discussion today. I'd also like to thank both our in-person audience here today and webcast viewers for coming up with some really great questions this morning. I've hoped everyone learned something new and valuable today, and I encourage you to share these insights with your colleagues. And if you know someone who is not able to attend today's event, please let them know that it will be available on the IPC's website, as well as on our YouTube channel this week. I'd like to conclude this morning's event with a roundup of some of the highlights and key takeaways from our panel guests. So Sylvie's work at Ontario Health is an important part of building a secure system for sharing patient information across all the different parts of the healthcare sector. She spoke about the work that the province is doing to roll out a model that secures healthcare providers from an evolving threat landscape. Among other features, the model specifies needed resources and removes silos for cyber attack response. Testing that model has been part of pilot projects across Ontario, and the model can also assist smaller providers with limited resources by establishing sufficient protection from cyber attacks. Michael noted that as we build up the digital health information infrastructure, the benefit will be the more secure exchange of information, the elimination of fax machines, and also better quality and more timely care for patients. The goal? Everyone from doctors to pharmacists can use one system to provide a better standard of communication and care for patients. Michael also spoke about administrative monetary penalties, or AMPs, and their important use for an independent regulator like the IPC to maintain the public trust in our healthcare information system. Wendy spoke about the important initiatives her office and St. Joe's have undertaken to move forward with digitally secure systems like their e-referral system. She also spoke about the vital need for accurate information to be shared when someone moves from the hospital to long-term care, for example, by utilizing digital platforms to safeguard the sharing of patient information and ensure the continuity of care. And impressively, St. Joe's also has over 7,000 healthcare providers using their secure portal to share health information instead of using fax machines. She also made the great point that curbing snooping and inappropriate access is an important goal that the entire healthcare system must share. This means that the rules for access must be clear, the consequences must be well known and framed in a just culture framework. What is done after such a breach occurs, such as notifying the IPC and affected patients, must be followed, and any lessons learned implemented. Nyranne noted that effective digital access for primary care and for specialist services remains a real challenge. The use of digital services can help to more effectively and efficiently direct patients to the services they need to access with minimal delay. And she also spoke about the Ottawa Hospital's implementation of a just culture to promote more quality choices in their healthcare system, together with the use of AI to audit their health information system to deter snooping, maintain security, and improve the culture of privacy protection. We also heard that the use of electronic medical records and secure digital systems can be a significant benefit for the patient experience, allowing specialist consults to happen much more rapidly through virtual meetings while minimizing the risk of breaches. Finally, Ariane highlighted the challenge of exchanging personal health information across healthcare providers, where patient records are not set out in a standardized way. We heard that long-term, Ontarians need better health information exchange technologies to move away from the healthcare sector's reliance on cheap, easy, and reliable, but unsecure fax machines. Ariane also noted that using effective digital health services can have a beneficial impact on addressing physician frustration and healthcare provider burnout. We also heard how cybersecurity risks can be minimized with appropriate education and training for all practitioners, using prevention tools like properly secured systems and appropriate password protection, and having a robust response plan that addresses the need to continue providing services. And finally, we heard from all of our panelists that we need to emphasize the importance of not just treating privacy superficially, but actually embedding a privacy culture within the organization as a foundational part of the healthcare system. Whether it's ongoing education and training, sharing privacy assessment reports throughout the organization, or supporting privacy tools for communications between patients and their healthcare providers, a deep institutional commitment to privacy is key to maintaining the security of our health system. Now, overall, it was a great panel discussion, and again, thank you very much. There were certainly a lot of interesting points made today coming from some very knowledgeable participants. And I want to reiterate the Commissioner's point at the beginning that the pandemic has brought a tremendous amount of change to our healthcare system, fueling the rapid digitization of healthcare. But given this rapid transformation, it's important we examine the use of legacy technologies like fax machines, which put privacy at risk and instead transition to more secure means of communication. Right now, the healthcare sector is the only major service area in our society that relies on fax machines. And, spoiler alert, the modern rarity and lack of security when using a fax machine is even a plot point in the recent Glass Onion movie. It's more than time to move on from past technology and fully embrace the new era of digital healthcare and the modern tools that are now available. Tools which offer far more security to protect personal health information, one of the most sensitive forms of personal information about all of us. A smooth transition to new ways of delivering and receiving healthcare can only come if we all work together. Patients, healthcare providers, regulatory colleges, and government. By embracing change and working together, we can ensure our healthcare system continues to evolve for the better and maintains the trust of Ontarians. And with that, let me finish by encouraging all of you to visit the IPC's website at ipc.on.ca to take advantage of all the resources we have to offer, including all the guidelines and fact sheets that are mentioned here today. Very important. They're a valuable resource for all healthcare providers across the province. You can also follow us on social media. We're on Twitter, Instagram, and LinkedIn, and keep up with the latest developments in access and privacy in Ontario. And please tune into the Info Matters podcast, where the Commissioner has some truly fascinating conversations with people from all walks of life about access and privacy, and it's available on our website and all major streaming services. Thank you very much for joining us today, and hope you have a great afternoon. Take care.